Well, I can't tell you what an honor it is to be sitting here today with Dr. Nizar Tanir from MD Anderson Cancer Center. Dr. Tanir runs the kidney cancer program at MD Anderson and has a wealth of clinical trials under his belt. Today we're actually going to be talking about non-clear cell kidney cancer. Dr. Tanir is going to elaborate on what that is and a very important study that he's led to address how he might actually treat that disease. Dr. Tanir, thanks so much for coming today.
Thank you for the opportunity, Monty. It's always a pleasure to be with you.
When I'm sitting down with a new patient in my clinic who has non-clear cell kidney cancer, tell me what that conversation might look like in the face of your data.
I think we will face the same patients again in my clinic, and I think there is, we have to tell the patients that there is really no substitute for participation in clinical trials. We are in desperate need to conduct more clinical trials in this diverse group of non-clear cell renal cell carcinoma, because unfortunately the drugs that we have right now in the clinic that have been approved, and you know we have 7 of them, and then we have 8 if you include high dose interleukin-2, all those don't seem to be effective in this subgroup of, in this basket or in this diverse group of non-clear cell, with the exception of chromophobe renal cell carcinoma. It was interesting to show that we were able to show in the ESPN trial that I'm presenting tomorrow, as well as in the trial we did before with single-arm sunitinib, that group chromophobe appeared to respond to sunitinib in both trials. In the first trial, there were 2 out of 5 patients, small number, but 2 out of the 5 patients had a partial response with a median progression-free survival of 12 months. In the second trial, the one I'm going to be presenting tomorrow, the randomized trial of everolimus versus sunitinib, the ESPN trial, the response rate was 25% for the chromophobe, and the median PFS was 9 months. And so for that rare subtype, the chromophobe, it appears that sunitinib has activity, and both with the response rate and progression-free survival, and these patients live about 2.5 or 3 years. And the same can be said about the everolimus for that subgroup of patients. Again, the numbers are small, but it looks like everolimus does provide activity with responses. In fact, one of our patients who had the best response had partial response when she was treated with sunitinib in the first line, and after she progressed on sunitinib, when she crossed over to everolimus, she achieved a complete response, and she is now 2 years out in complete response, having a chromophobe with 30 or 40% sarcomatoid component in her primary tumor. So obviously now our next step is to study these, now we refer to them as the exceptional responders or the unusual responders, to try to molecularly define their tumors, genomically, to see what pathways or genes are mutated that led to this dramatic response. But unfortunately, that remains the small number, the unusual, unusual number. So it's the majority of the patients, unfortunately, with non-clear cell, papillary, unclassified, and these rare ones we talked about, translocation, etc., do not seem to benefit much from the target agents we have. Only chromophobe appears to benefit from sunitinib or everolimus. So for the next patient I'm going to be seeing, you're going to be seeing in the clinic with non-clear cell, if they have papillary RCC, or if they have unclassified RCC, or if they have renal medullary carcinoma, or if they have translocation renal cell carcinoma, or MTS, mucinous tubular spindle cell, I think we need to encourage those patients to enroll in clinical trials. And we are developing now the next wave or the next set of trials for these patients. I think the hottest thing, as you well know, Monty, now is the immune checkpoint blockade agents that we have now. And we are hoping that we will be able to bring a trial with these immune checkpoints, such as the anti-PD-1 antibodies and the anti-CTLA-4 antibodies, to those patients with these rarer subtypes of RCC, because I believe the target agents have limited efficacy except for the chromophobe, as I mentioned, limited efficacy. So we really desperately need more effective therapies, and I'm hoping that the immune checkpoint blockade agents or some of the newer drugs that have been developed against CMET pathway, as you well know, for example, in papillary, may be beneficial in these patients with, for example, the papillary RCC types.